All right, we are ready to get back to our next session, and we are now going to go from return to learn to return to play, and we have Dr. Stan Herring on with us today to talk about return to play, and he is a UW clinical professor in the rehabilitation medicine, orthopedics, and sports medicine and neurological surgery. He is director of the University of Washington Medicine Sports Health and Safety Institute, medical director of sports, spine, and orthopedic health for University of Washington Medicine, and co-medical director of the Sports Concussion Program, which is a partnership between University of Washington Medicine and Seattle Children's. Dr. Herring specializes in non-operative musculoskeletal and sports medicine, with a particular interest in disorders of the spine and sports concussion. He has served as a team physician for the Seattle Seahawks and Seattle Mariners, and is a consultant to the University of Washington Sports Medicine Program. Dr. Herring was a major contributor to the successful passage of the Zachary Lightstep Law in Washington State, and has continued work that's helped pass similar legislation in all 50 states, including the District of Columbia. And so, Dr. Herring, we're going to turn it over to you and let you get going.
Thank you. Let me see if I can start my slides here for everyone. It's great to be here this afternoon. There we go. Listen, thank you. What a nice honor to be here this afternoon and to be part of this conversation, and all of my colleagues who have touched on many important topics. I have the pleasure now of talking about return to play. I will follow some of the work that has been done by Dr. Chrisman in her conversations with this group, and move forward about how to get young people active in sports again. My disclosures that may be relevant to this talk, although I have no plans on mentioning any of these issues directly. Certainly, the issue around concussion is one that is in every newspaper and on every sort of media form that we can find. It's become an incredibly popular topic for those of us who've been involved in brain injury for a long time. It's nice to see this topic get a lot of conversation. You can't go to any type of media and not find some conversation about concussion. While that's important, I think it's important for us to keep in perspective what Dr. Chrisman told you, which is this is an injury with a fairly favorable prognosis, yet it's the responsibility of all of us to make sure that we manage it correctly. People often ask if there's a concussion crisis. Certainly the number of reported concussions has increased, as you can see here in this graphic representation. Although realistically, this may not be truly a concussion crisis, more awareness and perhaps reporting bias. So concussions are not new. The problem is not new. The incidence may not have changed, but certainly the awareness has changed, which is a good thing, so that we can make sure we keep kids safe. You heard Dr. Chrisman talk a little bit about the pathophysiology of concussion, certainly based on animal models, and probably has some validity in humans as well too. After a blow to the brain, there's loss of membrane homeostasis in the part of the brain which is injured, and calcium influxes into the cells. Potassium sort of effluxes from the cells, calcium influxes and actually binds to the mitochondria. This problem requires energy to fix, to regain homeostasis. The brain is not a storer of energy. The brain receives its energy through blood flow. Ironically, the part of the brain which is injured after a brief period of increased cerebral blood flow actually has decreased cerebral blood flow. And this situation of increased metabolic demand and decreased blood flow creates a fuel supply and demand mismatch. And this is often referred to as a sort of brain energy crisis. This is relevant in terms of return to play, understanding that the recovery of this energy crisis may be necessary, is necessary to help make sure that the brain is protected. And another way to state this is that the brain is injured with a concussion. That injury evolves over minutes to hours There is a need for more glucose, but there's decreased cerebral blood flow. That's regional based on where the brain is injured. And that fuel supply and demand mismatch leads to neuronal tissue vulnerability. And it is during that time of neuronal tissue vulnerability that a second blow to the brain can have rarely devastating, but often significant consequences, prolonging recovery. So as Dr. Christman said, return to learn prematurely will not damage your brain, but return to play with rigorous physical activity and the chance for further impact on an incompletely recovered brain may indeed truly have injury issues to the brain itself. Of all the advancements that we made in medicine, really nothing makes that recovery occur more rapidly than time. It doesn't help to ice your head, as we like to say. And so this is a time-dependent recovery, and ironically, it appears that actually youth may take longer than adults. One of the few times that being young may not be to a patient's advantage. These are incredibly common injuries. This is work Dr. Ibarra and some of his colleagues showing that sports and recreation-related concussions in young people are remarkably common. It's perhaps as many as 1.9 million a year in youth alone. As Dr. Crispin said, many times those concussions are not seen by any healthcare provider. Once again, a usual favorable natural history. And of those seen in healthcare settings, the great majority are seen as outpatients. So looking at emergency room or hospitalization data may give a skewed sense of how common these sports-related concussions and recreation-related concussions really are. This is a bit of a good news, bad news situation. Obviously, the great majority of people who have a sports concussion, youth included, do not end up with long-term brain problems. It's an incredibly common problem. However, there are some that do. Given the great number of concussions that are seen in the United States, there will be some students and student athletes who do not recover on the usual time curve. Listening to Dr. Fuentes for the more significant brain injuries and Dr. Crispin about return to learn makes us understand that we need to do a thorough evaluation, particularly for those with persistent or protracted recovery. Zach Lystedt, you heard Dr. Crispin mention him as an example, a young 13-year-old state of Washington football player who unfortunately continued to play with clear concussion symptoms and had life-threatening, remarkably devastating consequences, and through heroic measures has recovered to a remarkable degree, but still faces lifelong challenges. A preventable return to play problem if he had only been held longer and not allowed to return to the same contest or until he was all the way well, he and his family would not be suffering the great challenges that they are today. There are a variety of signs and symptoms of concussion for those of you on the field of play or on the pitch side. The symptoms are quite variable and depends upon the part of the brain injured. The most common, as Dr. Crispin talked about, were the confusion, headache type symptoms, but many athletes have no confusion, but they may have a vacant stare or inability to focus. They may have light or noise sensitivity, or they may have acute emotional lability or change. That's why a dedicated or disciplined assessment on the field of play is necessary, asking about symptoms in these different domains, cognitive, somatic, or affective, almost always after the day after a mild traumatic brain sport. There are some sleep components too. The patient will complain of being drowsy or sleeping less or sleeping more or having trouble falling asleep. Before you can make a decision about return to play, we have to make sure we diagnose the concussion accurately, and that does involve a careful recounting of the mechanism of injury and the symptom complexes that may be present depending on what part of the brain is involved. As you've heard today, in terms of sports concussion or mild traumatic brain injury, the great majority resolve in a short period of time. Once again, it may take longer in children and adolescents. So it's not uncommon for these problems to be better in a week or two. However, there are a certain number of athletes who really don't recover quickly. If you look at this epidemiological study of more severe injuries for brain injury and concussion, it's not uncommon, for example, in boys soccer for about 12% of athletes to have lingering symptoms as long as 3 weeks out after a mild traumatic brain injury. What's important here is not only that they return to play safely, but as Dr. Crispin mentioned, these are not just athletes. There's an adjective that comes before the word athlete, and that's student athlete in this case. And these student athletes may indeed miss sports, but they also miss school and social development and outside school extracurricular activities, all of which can have a profound impact on their status and development. So we want to make sure that we manage return to play correctly, along with return to learn correctly, so we don't prolong recovery in athletes who may be at some risk, in certain cases, have symptoms which last a few weeks, not just several days. Dr. Crispin talked about the Berlin Consensus Conference. This was recently held in Germany, and the reference here is freely downloadable for you. But there were new discussions about recovery after sports-related concussion and return to play, and I will share some of those with you during this presentation. This year, we did talk about the idea that it is reasonable to conclude that the large majority of injured athletes recover at least clinically within the first month following an injury. Now, there may be neurobiological markers, advanced imaging, serum markers, electrophysiological tracings, and even some genomic work that may show changes that linger longer. Those are interesting as a research tool, but clinically, most patients are better with it. Young patients are better within a month. And significantly important is that there is a growing body of very high quality literature suggesting that psychological factors seem to play a significant role in symptom recovery and symptom persistence. And this is, once again, when you're making return to play decisions, we often talk about what did the athlete bring to the concussion that makes him or her perhaps more at risk to have prolonged recovery. Dr. Crispin mentioned that the symptom burden is an important indicator for recovery, and the strongest, actually, and the most consistent predictor is the severity of the initial symptoms following injury and the number and burden of those symptoms. Conversely, if you have low-level symptoms on the first day following an injury, there is a favorable prognosis, and the development of persistent problems such as headaches with a migrainous character to them or mood changes such as depression suggest persistent recovery lasting longer than a month. And children, adolescents, young adults with pre-injury history of mental health problems or migraine headaches disorders, once again, appear at more risk. So when you're seeing an athlete and talking about return to play, it's important to understand who that athlete is, and as we said, what they brought to the concussion, looking at pre-existing and coexisting issues as indicators for prolonged recovery, and also understanding the burden and severity and number of initial signs and symptoms associated with the sports concussion. Once again, in Berlin, we talked about those with learning disabilities and ADHD. It was felt that ADHD may be an independent modifier for prolonged recovery. It may not be so much prolonged recovery as it may be the challenge in managing that athlete with ADHD or some even with learning disabilities. So there's been a change to say that these young athletes don't necessarily recover more slowly, but the recovery process and the return to learn and return to play process may present unique challenges to the provider. There is very little research in terms of return to play for children under the age of 13. There is some evidence, however, that teenagers, particularly those in the high school period, may be the most vulnerable for persistent symptoms. And while this is discussed as being greater at risk for high school girls than boys, that conversation has many facets to it. It may be gender specific. It may be reporting bias. It may be other reasons, but it's just experientially, high school girls sometimes seem to take longer to recover from signs or symptoms of a sports concussion than their male counterparts. I'd like to give my patients sort of a roadmap for recovery to make them understand that the absence of symptoms doesn't mean normal function. So if we say that concussion symptoms may last 7 to 10 days, particularly if it's a mild concussion, but still there is the return to learn piece. And as Dr. Crispin said, that may start day one, but there may be some delay. And certainly before there's an attempt to return to play, the child must be able to not only go to school, but go to school and do their work with the same effort, do their homework with the same effort, be doing extracurricular activities and social activities with their normal amount of energy without signs or symptoms. During that time and subsequent to that time, a gradual exercise challenge, just like the gradual academic challenge that Dr. Chrisman discussed, may be very reasonable. But before there's return to play, these steps must be followed. So there is not uncommon for this to be a 2 or 3 week or even a month injury once all these steps are taken. These are essential steps to make sure that the athlete has met milestones so they actually can proceed safely to return to play and let the brain biochemistry recover to baseline. But once again, these are average estimates. Each concussion is unique. They're described as snowflakes, no two are alike. Even before the season starts, if you have the opportunity to be helping with team care for a high school team, for example, it's nice if you have an emergency medical action plan. I would say that's essential, and that should include guidelines specific to concussion management. If you're lucky enough to have an athletic trainer on staff, that is a huge benefit. Some standardized baseline assessment, particularly in collegiate and professional levels, beyond what the athlete's learning style, memory, concentration, and other skills are before the injury can be helpful. There is a tool, the SCAT-5 and the Child SCAT-5, which came out of Berlin too, freely downloadable, which can be used to take down baseline data. This is a little different than baseline neuropsychological testing. Dr. Chrisman talked about paper and pencil testing and robust all-day testing. There are shorter computer-based testing modules that have limitations. They can be helpful, particularly for reaction speed, but are only as good as the person performing the test and interpreting the data. And then it's nice pre-season to have a team in place in case an athlete does suffer a concussion or other injury. And it's certainly nice to use that pre-season to educate all concerned parties about concussion and other health-related issues. This is really a good time to make the parents, coaches, and school officials understand what your role is as the healthcare provider for that team. The SCAT-5, this is a tool which has instructions with it. It is free. It is a nice tool to use both at baseline and after injury. It does assess concussion history, and it does get baseline values for symptoms, orientation, memory, concentration, and balance. And these can be useful tools for comparison's sake after the athlete is injured. There's a Child SCAT-5 version, and then there's a concussion recognition tool for coaches and parents. We do not want parents and coaches diagnosing concussion. Their job is to be aware of it and remove the athlete if there's any suspicion. Diagnosis of concussion is a medical issue. In terms of continuum of care, what happens on the sideline, what happens in the clinic, and what happens in terms of return to play. On the sideline, it's so important if you're covering on game day, it is essential to have your game day medical action plan, that emergency medical action plan in place, and implement it, making sure that all components are available, access to the field is available, everyone knows their duties, and that you have communication to others, and certainly to an emergency room, and understand that any athlete who's down on the field with a suspected head injury and not is moving has a suspected cervical spine injury at the same time, and cervical spine immobilization procedures and emergency transport are necessary. It is essential, if you see an athlete on the field, to evaluate them in a systematic fashion, certainly looking for circulation, airway, and breathing, and then making the decision by a focused neurological assessment as to whether or not this may indeed be a mild traumatic brain injury or more severe brain injury, assessing cervical spine status, and then making a disposition. Is this an emergency room transport, or is this further evaluation on the sideline? If you do choose to evaluate the player on the sideline, make sure that you take in detailed history and perform a more detailed physical examination. And once again, this is where the SCAT-5 form, the Child SCAT form, sideline concussion assessment tool can be helpful. It forces you to be disciplined in that assessment. And if you have baseline data, comparison can be helpful. And then once again, if you can assess for the number and burden of symptoms, this will have prognostic significance, and you may know fairly early on, at least prognostically, that you may be looking at someone with a longer recovery or hopefully a shorter recovery. But once again, it's also incredibly individual. However, if there is even a suspected sports-related concussion, the athlete should be removed from the sporting environment, and as we've said, be assessed. That sporting bodies need to allow an adequate time to conduct this evaluation. This is Berlin Conference information. It takes about 10 minutes to perform the SCAT alone, and so we want to make sure that no healthcare provider is pressured to make a shorter evaluation, and the governing rules of sports do not limit a very careful evaluation. There needs to be a place to do that evaluation. And the final determination is not just based on the SCAT-5 or the pediatric SCAT. It's a medical decision based on clinical judgment. There is no one test to make the decision about removal from play, nor is there one test to make the decision about return to play. And once again, referring to the SCAT-5, however, the SCAT-5 itself notes that scoring of this test alone is not a standalone method to diagnose concussion, measure recovery, or make decisions about the athlete's return to competition after concussion. This is not a standalone tool. There is no standalone tool. It's a helpful adjunct. But remember, this is a clinical judgment about both removing from play and returning to play. It is essential to understand that the safest course of action is to hold an athlete out. If there's any suspicion of a concussion, when in doubt, sit them out. If everyone you remove from play ends up having a concussion, you're probably not removing enough athletes from play. And as far as return to play, even dating back to the Zurich conference, the same group, but in 2012, it was a unanimous agreement that there is no return to play on the day of concussive injury, even if the athlete feels better. There is no same-day return to play because you still don't know if the symptoms are going to blossom over minutes to hours. And this is true for all levels of athletic competition, not just for youth. In terms of clinical management, post-game day evaluation and treatment, it's really important to obtain a comprehensive history of the current concussion and of any previous concussions. Perform a physical examination, once again, a detailed neurologic examination. You can use the SCAT tool or the SCAT-5 tool as a component, but that SCAT tool is really most valuable in the first few days after a concussion. You must make a decision whether you need further assessment or consultation, and whoever is managing this concussion needs to control the return to play status. That athlete should not leave your office or your clinic without the healthcare provider being in control, saying you are not cleared to return to play or you are cleared to return to play. Grading concussions 1, 2, 3 has often been used in the past, but is really based on loss of consciousness. Brief loss of consciousness is not a very good predictor for outcome, and we've moved away from using grade 1, 2, or 3 when evaluating concussions. Dr. Chrisman talked about the importance of physical rest. Activity certainly can exacerbate symptoms and prolong symptoms. It doesn't damage your brain more unless you take another blow perchance, but it does prolong recovery, at least in the short term. And she talked about not only physical activity, but relative mental activity as well too, not just schoolwork, but texting, video games, and others. However, as Dr. Chrisman mentioned, and once again discussed in Berlin, the basis for recommending physical and cognitive rest is important for the acute recovery. However, there really is current insufficient evidence that suggesting that strict rest beyond 24 to 48 hours is helpful. And indeed, as she quoted the Danny Thomas and other studies, it actually may be harmful. So appropriate medically controlled early activation, daily activities, not sporting activity or aggressive exercise, and some cognition turns out to be the way to go for the great majority of these young athletes. So the prolonged cocooning, as she said, we're trying to move away from that. Often people think there's a neuropsychological test, a computer test that can be used not only in the preseason, but as a postseason test to see if the athlete remains concussed. Once again, there is no single test. Computerized testing has limitations, and it does have some advantages. You need to understand the indications and limitations of the testing you choose. That includes type and content of test data, player age. Many of these tests are not very helpful for young children below the age of 12 or younger. And this remains only one component of the evaluation test. Just so we're clear, you can have a normal SCAT-5, you can have neuropsychological testing, which is at or above baseline, and the athlete can certainly still be concussed. it is essential to understand that there are modifiers in your return to play decision. It turns out that the severity of the current injury, as we've talked about, the previous number of concussions, how close together they were, how severe. It is not a good sign if a mild blow to the head causes significant symptoms. Remember, the younger brain it takes longer to recover. Certainly, sports that are contact or collision by nature, some caution must be considered before return to play. And as we talked about, learning disabilities maybe don't make the recovery longer, but make it more challenging to manage at times. Same thing with ADD and ADHD. And certainly, anxiety and depression is a huge factor in prolonged recovery, as is migraine headache, pre-existing or coexisting. Actually, even a family history of these problems may portend longer recovery in certain athletes. And once again, these are all important modifiers, but concussions are all individual and never managed by calendar. You cannot tell someone that they had their concussion that they'll be out for 1 week or 2 weeks. You don't know until you continue to follow this. In terms of return to play, it is essential that you make sure that the athlete is at baseline cognitively and physically before resuming significant exertional activity. They need to have successfully returned to learn, as Dr. Christman so clearly discussed. And then you need to challenge them. Your body and your brain have to work harder with aerobic exercise and resistance exercise. And you may have athletes who feel fine until you exercise them under control and then their symptoms return. There is no concussion-proof piece of equipment. It's important that equipment fit well. In some cases, perhaps will mitigate concussion, but that is something which is a benefit and cannot be dependent upon. So there's no magic mouth guard or helmet or liner that will cause concussion prevention, but certainly equipment should fit well. Just like there's a graduated return to learn protocol, there is a graduated return to play protocol. This is from the 2012 consensus statement. If you pull the Berlin consensus statement, it also has a graduated return to play protocol. And as you'll notice here, there are stages: aerobic exercise, followed by sport-specific exercise, followed by training, and then contact. For children and young people, at least a day per step. And if there's a recurrence of symptoms at any stage, then returning to the previous stage, and then resuming activities with a 24-hour rest period. And once again, this is a medically supervised return to play protocol. So if you're taking care of high school athletes and you have a lacrosse player who gets concussed on a Friday afternoon game, you may tell her coach that it'll be good to see when her symptoms get better, but before she goes back to lacrosse, she needs to go back to school, and then she needs to go through a graduated exercise program. So it may be 2 or 3 weeks before you see this player again, even if she's feeling better. Helpful to have that discussion, particularly in the preseason. Dr. Christman mentioned youth concussion laws. Not only is it our responsibility to make sure that athletes meet criteria for return to play, it is now a law in all 50 states. Here's a picture of Zach Lystat celebrating the passage of the Lystat law with the governor of Washington at that time, Governor Gregoire. And the law is pretty simple. There are 3 major tenets. There needs to be education of athletes, coaches, and parents. There needs to be removed from player practice at the time of a suspected concussion, and no return to play until they're cleared by a licensed healthcare provider. In the state of Washington, that means written clearance by that healthcare provider. So this duty falls upon us to take ownership of this. There are pitfalls. You can mismanage an athlete at the time of a concussion. That's what happened to Zach. Or you can be challenged by athletes' persistent symptoms. What did we learn in Zurich? We learned that sports-related concussions can result in diverse symptoms and can be associated with other injuries, cervical spine injury or the peripheral vestibular system. And a variety of treatments may be required for ongoing or persistent symptoms for athletes who do not fall within the normal recovery curve. And activating these athletes early through things such as submaximal exercise and vestibular treatment, as well as a collaborative approach to treat cognitive symptoms, may be very beneficial. We have learned that persistent symptoms do not reflect a single entity. It may be many different things. and a comprehensive assessment needs to be understood. It needs to be undertaken to figure out why certain athletes trail in their recovery, and that there is insufficient evidence currently for advanced imaging techniques to help make this diagnosis, or advanced electrophysiologic techniques. This remains, once again, a clinical decision and clinical intervention. Treatment should be individualized. There is no question about that. It is not one size fits all. There is preliminary evidence that an individualized program using challenge with coordinated and supervised exercise, targeting a physical therapy program for those patients with cervical spinal vestibular programs may be helpful, and a collaborative approach work done at Children's in Seattle looking at cognitive behavioral therapy is very helpful for many athletes with persistent mood or behavioral issues. There is limited evidence to support the use of medication for persistent concussion symptoms. And if medications are used, it challenges the return to play decision. Should the athlete be off those medications before return to play if the medications may be treating or masking some symptoms? And the bottom line is this: if you're taking care of a young athlete with persistent post-concussive symptoms, and they've fallen outside the normal boundaries of recovery, managing these athletes in a multidisciplinary collaborative setting appears to have the best chance of helping them limit. We have to take brain injury seriously, yet if we attribute all symptoms to the concussion and don't look at other coexisting, pre-existing, or resulting problems, we run the risk of unnecessarily disabling young people and denying them their academic return to activity, as well as the critically important physical activity and the lifelong benefits that exercise and sports participation bring. I do always ask the parents who are prematurely want their son or daughter back in, I ask them, I say, really, for your adolescent, is this game worth risking the rest of the season for your athlete? Is it worth risking the rest of their career, take an injury and make it into something so persistent that they can never play recreational sports again? And rarely, but realistically, would you be willing to risk the rest of the athlete's life? So return to play is a medical decision. It's a decision made by healthcare providers with knowledge about sports-related concussion. It's done in the light of most athletes recovering favorably, but that still means every athlete needs a comprehensive and thorough evaluation to make sure that we are not misdiagnosing, underdiagnosing, or forgetting about certain criteria for return to play. Stepwise fashion, this return to play decision starts in the preseason, extends from the sideline or the pitch to the exam room, and then back to the field to play, all done under medical supervision. We need to help keep sports safe, because sports are good for kids and they're good for kids' brains. And let's see if we can help them be safe from concussion. I am very grateful for the attention that this topic has been given today, and it's a pleasure to provide this information for you. Much of the information that I mentioned is either on our Sports Concussion Program website or our Sports Health and Safety Institute website, if that may be of value to the listener. And I believe I had 35 minutes, and I should be pretty much on time, and that should give us time for questions and answers, if there are any.
Yeah, you're right on time, and we are going to, you got 10 minutes now for, or maybe 10, 11 minutes for questions and answers. So if you've got a question or a comment, if you can type that into the question and answer section, and Dr. Herring will respond to that. While we're waiting for some of those people to ask some questions there, we did have a question comment that came in on the chat screen, and I'll read that off to you. This is from Brenna Hughes in California. She says, in Central California, we have a major issue with awareness in all areas, including physicians, in part because there's not special certification for physicians to obtain to be able to clear athletes to play. We even have neurologists who have told pediatric patients that concussions are not cumulative. They see clearance notes from doctors that say things like, he's not able to play football, but he's cleared to only play basketball, or he's cleared to return to play only the kicker position. do you have any suggestions for schools who have kids cleared by a physician for return to play while still symptomatic and no return to learn accommodations?
Thank you for the question. And if it makes you feel any better in Central California, you're not alone. This is a common complaint, and I think part of how medical knowledge moves forward. We have made significant benefit. Our research with our colleagues at Harview Injury Prevention Research Center have demonstrated that coaching knowledge and parent knowledge about concussion is at an all-time high. Changing the behavior has followed a little bit more slowly, but we still struggle with some variability in the healthcare community about physicians' knowledge and behavior around sports concussion. There are many resources. The CDC has a freely downloadable clinical care provider 45-minute video that covers many of the things that you've heard today. Most major professional medical associations, the National Athletic Trainers Association, and many others also have educational materials. The CDC has very good material. One thing that we've done as we've tried to help our colleagues become consistent with their approach is if you have a preseason plan, an emergency medical action plan, and if you are the team physician or if you have an athletic trainer at your institution, we have said that no matter what outside note that is received, that athlete still must be cleared by the team physician and the school's athletic trainer. And that has taken the politics out of it a bit and just made that a school or a league policy. That's one intermediate step you can do. The second thing is take control of education in your community, seminars, resource material. I don't think anyone wants to hurt a young person. We are spending a lot of effort trying to educate physicians, but in the meantime, speak up. Everyone should have a veto vote, including the coach, including the parent. And if a healthcare provider provides advice which you think may not be as current or as appropriate, either a direct conversation with them or try to manage that through school policy.
Thank you.
I see a couple of questions that have popped up. Should I read those and answer those? Let's see if we
go
can
ahead.
do that. Is there any evidence that differentiates between return to play recommendations after moderate to severe brain injury that require inpatient rehabilitation versus concussion? This is a very important question. What do you do about the patient with a moderate to severe brain injury who then wants to go back to recreational activity? While there are no hard and fast rules, I think in situations like that, Dr. Fuentes becomes a very important part of our decision-making rubric. Certainly, if there are residual neurological deficits that would affect motor performance, balance, cognition, then doing sports where there is a chance for significant injury, whether it's cycling or playing collision or contact sports, has to be taken into context. Not only do you want to not injure their brain further, you want to make sure that you don't have them susceptible to other orthopedic or medical injuries.
Dr. Aaron, we just want to let you know that your signal froze and we've lost your audio there for a second. You might see if you can reset that on your end and pick back up. There, we can see you now.
Okay, I lost you. Yeah,
There you go.
guys for a second.
All right, good job.
I thought maybe that was an unsatisfactory answer, so you just disconnected me. But let's see. That I think wiped out the questions that I had in my box, so I can now wait for others. There was another question, but it was lost with that brief disconnection.
I'll read off the second question to you. It was, what resources are there for the rural family practice providers and mid-levels that are writing out clearance notes to learn the current standards in sports programs not large enough to have a sports trainer? Dr. Herring, if you can hear us again, we lost your video feed or you froze again, and we've lost your audio. We'll give Dr. Herring just a minute or two to see if he can get reconnected and try to re-answer these questions. If we don't get him back on, then we will make sure that we get those questions out to him and follow up with everyone afterwards as well. Let's see if we got him here.
Yes, I'm sorry. I obviously
problem.
I am remote.
All right, so we're still having some technical issues. Dr. Herring is coming in remotely and has some limitations on the bandwidth from where he's at, and was just unavoidable, unfortunately, for our thing. But we will make sure that we can follow up with him on any questions you have. We'll keep the question and answer open. Dr. Herring, you want to try it one more time?
Yes, I don't know when you lost me. CDC, UW Medicine Sports Health and Safety Institute. We have a variety of materials for you, and also Berlin Consensus Statement. You can search for it on any search engine, type in SCAT5, all that material is freely downloadable.
Very good, thank you. Any other questions? All right, I don't see anything else coming in. Dr. Herring, thank you so much for being on and sharing with us today. Very valuable information, a lot of great work being done, and we all appreciate that. If anyone has any further questions they think of later, just feel free to connect with us, and we'll get you connected with any of the speakers that you need. And
great to be with you. Thank you.
Thanks, Dr. Herring. All right, we'll go to our break now. We'll see you guys back with our final speaker at 3 o'clock. Thanks.